Okay, I think we can get started as people come and join in. So thank you everybody for joining in. We are coming back with our Observation Journal Club after doing our series of lectures. And the topic today was heart failure, which seems to be, pretty bread and butter um, diagnosis that we manage in the hospital. But the 2019 guidelines sort of was a refresher to the previous focused updates that was published by the ACC and the AHA, and highlights a lot of different things that are incredibly useful for our day-to-day management of congestive heart failure. So we're highlighting this article specifically that I sent out to everybody this morning. One, because of the importance of moving away from just focusing on guideline management therapy to actually looking at what is happening on the management side of heart failure during the hospital and also at discharge and how the transition of care is happening. Um, but also Henry Ford's renewed efforts in trying to bring down our heart failure readmissions. So we are looking at heart failure from a very broad perspective, both from the outpatient management perspective as well as the inpatient management perspective, and also regarding the transitions of care that happens in heart failure. So this guideline was interesting in a way that it looked at all of that. It was more practical, in the words of Dr. Felix Rogers, who's one of our Wyandotte cardiologists, who was part of our meetings when even cardiology team members are excited in looking at this updated 2019 ACC consensus on heart failure management. So what's so different in this guideline? I'm pretty sure we've all seen guidelines before. This was not published as more of a guideline. This was a consensus statement, more of an expert panel consensus on how heart failure management should be standardized throughout the inpatient practice, right from the ED to the observation unit to the floor to the ICU, and then what happens on discharge, at which points, all of these factors needs to happen. So all of this was very variable between different hospitals, between different health systems, between different providers. So this consensus gives us a way to put everything together so that we are very consistent, irrespective of where we practice. So let's look at some of the highlights or some of the scope of why this was focused on at this time. So nearly 8 million people are expected to be affected by congestive heart failure, both by reduced ejection fraction and also by preserved ejection fraction types of heart failures, which comprises nearly 1 to 2% of all healthcare spending. Now, considering that healthcare itself consumes about 16% of our GDP, this amounts to anywhere from 50 to 100 billion dollars a year that is being spent on heart failure management. And any heart failure admission, regardless if it's for systolic or diastolic heart failure, increases the mortality for the patient. Sometimes even up to, if they're coming in with cardiogenic shock and it being admitted to the ICU, their mortality risk goes up as high as 30% sometimes. And a lot of these patients are admitted from the emergency room, so very familiar to all of us in how we manage these patients, right from the ED to the observation unit to the GPU, and also receiving patients from the ICU or managing them from the ICU. So this update was more of a focus on what happens in the hospital, how the transitions of care happen, what are the decision points that we can use to make those transitions, and more focus on how to achieve decongestion in these patients rather than a heavy focus on just talking about guideline therapy. And this was essentially diagnosis neutral in the sense that it applied to both diastolic heart failure patients, systolic heart failure patients, and also heart failure with mid ejection fractions, those patients where they're 40 to 50%, where they really don't qualify for full-blown guideline therapy, but then they're still at risk of developing worsening heart failure and coming back to the hospital. So this is essentially the core of this article is it talks about the clinical course of heart failure right from admission to transition to oral therapy and discharge and the first follow-up visit. And they focus on different nodes. What are called as nodes are these little like compass marks that you can see, and they describe, several of these nodes right at the time of admission, right at what we call as trajectory check, which we're going to see what that is all about. And at the point of transition, which they also focus on, and also this phase where you have this transition point to discharge, which is often the phase that is less looked at. We look at the admission phase, the trajectory check, essentially looking at to see whether they're responding to it or not, and then we make a transition and immediately discharge follows up almost within the same day or the next day. But they also pay more attention to this optimization phase where a lot of focus is on at this time because of increased readmissions. And also the early post-discharge phase where after discharge, what really happens to these patients? Like, are they taking their guideline-directed therapy? Are they following up with their primary care or their cardiologist? Are they following up with their cardiac rehab plans? And what happens at their first follow-up visit? So this is like a very broad perspective. I'm not going to touch a lot on the follow-up perspective. I'm just going to focus more on what happens between admission to transition to discharge, and what are the different highlights that have changed or that are a little different in this update compared to 2016 and 2017. So, the first decision always is whether this patient needs to be in the hospital. And they give a clear algorithm on deciding about who is a high risk patient, who needs to be in observation, who can safely be discharged from the ER. And essentially, the decision point starts from, is this patient, critically ill to need the ICU or not? Do they have a prior history of heart failure? Some emphasis in this guide on admitting new onset heart failure patients, which is something we have done here at the main hospital, at the main observation unit, and I'm pretty sure it happens across the system as well. And also to assess for marked degree of congestion. And we'll see in a little bit about what they actually mean about marked degree of congestion. And also, what is their medical risk and what is their complexity? So this is often a point of contention where, really high-risk patients are admitted to a low-risk environment, and then you end up having problems because they're not adequately diuresed on day one, and they lost their trajectory. They're not improving, and then we end up under-treating them rather than treating them appropriately. And also focusing more on, gathering that history, which is often very relevant and core to management of heart failure, whether they were prescribed medications or were they prescribed the right dose? Did the patient pick up that dose of diuretic? Did something change in their comorbid conditions? Did something change in their social determinants of health? All those factors also needs a reviewed focus for a successful management of heart failure in the hospitalization. And as you can see, this observation is really at the last end of looking at the different factors um, that determine whether a patient is going to come to the observation unit or is going to be admitted. And we'll look at the risk factors, and then we can, make a little decision on how relevant this algorithm is for us. So a lot of decision points is going to determine on what is your risk of the patients coming in. So are they, grouped under intermediate risk and immediate risk? Immediate risk is pretty obvious. They're hypoxic, they're in cardiogenic shock, they're in acute respiratory distress, they're anuric. All these patients require ICU admission. Often the big point of determination is what do we do between intermediate risk and lower risk. So understanding intermediate risk a little bit better often helps us to make that decision a little more clearly. So new onset heart failure obviously comes under intermediate risk, and even on the algorithm, they recommend that these patients should be evaluated more closely with cardiology. And low blood pressure with shock or hypoperfusion, patients coming in with unexplained sinus tachycardia or have atrial fibrillation, who have an acute decompensation of their renal function, especially who have doubled their creatinine. If they have a baseline creatinine of 1.5 and they come to you with a creatinine of 3.0 and they're in heart failure, these patients are not going to recover in the first 24 hours. So that's a consideration for admission. If they are hyponatremic and they're having a new hyponatremia, which is lower than their baseline level, these patients are again at risk of not improving within the set time frame in the observation unit. Obviously, patients with elevated cardiac troponin and degree of BNP elevation is another important, interesting biomarker that's discussed in this article is how they determine the level of BNP increase, actually predicting some of the prognosis of these patients while they go through the hospitalization. So if their BNP, doubled or tripled, if they have a baseline BNP of 400 and they come to you with a BNP of 2000, that patient probably is not going to do well in an observation setting. So those patients should be considered for inpatient admission, and also patients with liver dysfunction. So just looking at these risk factors, it kind of gives you, we've been doing this a lot of times. We've been reviewing these labs on these patients, and a majority of them do go inpatient, but this guide sort of gives us a backing to say that these patients are not gonna improve within that time frame in the observation unit. And also looking at the other risk factors that patients come in, especially anemia, iron deficiency anemia is being recognized as one of the factors that can contribute to worsening heart failure with reduced ejection fractions. So are they really iron deficient? Is correcting anemia going to help them? Those factors needs to be looked at, and also excessive alcohol use and endocrinology issues, and also infections. And another thing that flies under the radar is valvular diseases. Patients with valvular diseases and heart failure, often having preserved ejection fraction, are usually patients who don't do very well and probably need cardiology opinion to proceed with the diagnosis plan or the diuretic plan. All right, so it's very important to know where your patient is, and this is, I would say, probably one of the slides that I guess everybody should know and categorize your patients on where they fall, because your patient, depending on where they fall, they're going to have a much higher mortality risk. So those patients who are warm and dry are nice and happy. Those patients who are cold and wet are the ones who are at increased risk of decompensation. So it's very important to know where they are in this classification. And there was a study back in 1976 by Forrester who classified all these patients into the four different categories based on their pulmonary wedge pressure and also their cardiac index. And what was interesting in this study is they also defined what is the mortality of these patients in the first year. And you can see that if they come in cold and wet, they have nearly a 50% mortality. Now, this may not be true now because this was 1976. We have much better medications that are available that improve this mortality, but still the general idea is our goal is to move these patients from a cold wet state to a warm dry state. Now this happens fairly quickly if they come in with well perfused extremities. If they're warm and wet, then getting them warm and dry is often easier and quicker. So these patients are good observation candidates, whereas these patients which come in who are cold and dry and also cold and wet, especially with poor perfusion of their extremities, often means that they have low cardiac index, and if they are also congested, that puts their risk at a pretty high level. So understanding this is also going to help us determine how aggressively to diurese them to begin with, and what levels of care we need to get involved. So if you see a patient in the observation unit who's congested, but then you touch their extremities and they're cold, I would be very worried about that patient. And if they're not making enough urine and you diurese them and they are getting more hypotensive. Those are the patients that we need to identify early on and have expert cardiology consultation or to move them to an inpatient level of care. So it's important to understand the classification that Forrester proposed in. All right, so let's move on to management. So now you have, diagnosed them. You know that they're in heart failure. So what do you do? How do you diurese them? And this is something that I feel really good that we have now a guide that says, okay, this is the dose of diuretics that you got to use, so that we are one uniform, and also number two that we use pretty good dose, an appropriate dose early on in these patients rather than try a very low dose to begin with. So they say the initial IV loop diuretic, either given early in the ER or in the observation unit or on the inpatient unit, should usually be 1 to 2.5 times the total daily oral loop diuretic dose in patients who are taking them as an outpatient. So your initial dose should be at least 2 times higher than their outpatient dose. Um, and if you're prescribing an IV drip, we'll see what are the recommended doses based on this article for IV drips and also IV doses. So essentially, once you diurese them, you're going to monitor their symptoms, their signs, their urine output, their electrolytes, and then decide on which trajectory they are. Are they in the green trajectory? Are they moving towards their target? Are they, improving and then stalling? Are they not improving? So depending on that, if they are improving, then you continue the therapy. If they are not improving, if they are stalled, then your secondary agents come in where you can add metalizone, or you can even increase the loop diuretic if you don't have them on a higher dose already, by nearly 50 to 100%. So essentially double their dose when they come in, check their trajectory, and then double their dose if they're not improving. So I'm really glad that they put this as a guide so that this is done uniformly across the board, rather than starting off at very low doses and then saying that they are not improving. It may not be true because we didn't start them off at the right dose to begin with. So what doses to use? Especially loop diuretics. When you talk about loop diuretics, you really have to give the right dose, because if you don't, they're not going to respond. And the recommended dose for these patients is starting at 40 IV and up to 3 times a day. And it's very interesting that they recommend, a pretty high dose to begin with. Often we see some patients when they come in, they're started on 20 milligrams of IV Lasix, which I feel is extremely underdosing patients. So you have the liberty to start them off at a pretty high dose. So let your starting dose be very aggressive. And if they're in the observation unit, aggressive diuresis, getting them optimized early on, especially when they have room in their blood pressure, is often going to make them improve faster. And similarly with drips as well, to be more aggressive early on rather than be soft early on. So if you're doing your IV dosing, remember to start higher there as well. So this gives us a fair idea on where to begin and then how to continue going forward. So coming back to, so we talked a lot about the admission node and now coming to the trajectory check. So we talked a little bit about this. So once you diurese, you stop, you reassess. You could have given a couple of doses of diuresis. Your trajectory check may be as early on as 12 hours into the patient admission, or your trajectory check may be 36 hours into the hospital admission. No matter where you do your check, after giving their appropriate dose, assess and see how they're doing. Are they improving towards their target? Then you're on track. If they're not improving, consider doubling their dose or consider escalating their therapy, consider a different diagnosis. Now is the time to see if you need the help of cardiology. But all that after starting off at the right dose initially. So the goal of this paper was to emphasize on the pathway of bringing these patients from congestion to decongestion. So essentially, If you are not seeing a reduction in their weight, if you're not seeing a reduction in their, BNP levels, or if they're not having improvement in signs and symptoms of heart failure, then you're not doing a good job. They're still congested, and you need to reassess to see if they have any common reasons for these congestion. Are they having a low cardiac output? That is often the first concern. Do we need to take them for invasive studies to determine their cardiac output? Are they having, right heart failure from another cause like significant pulmonary hypertension that you're really not addressing? Are they having advanced renal disease that is making their diuretic doses not as effective? So that's something to consider. Um, and also assessing some of the other patient engagement issues. Are they really not interested in their care? And to understand some of the signs of clinical congestion. So essentially, when you're deciding on is this patient ready to leave the hospital or to be determined as decongested, you need to make sure they have minimal to low peripheral edema, that they are not having pulmonary edema, that they're not having congestive GI symptoms, loss of appetite, they have elevated liver enzymes. And this is another term that they've introduced since 2014 called as bendopenia, which is a sign when the patients are bending down to, touch their toes or tie their shoelaces. They often get really extremely short of breath. And that's often noted as a sign of poor improvement. So even though they look good, they don't look peripherally congested. But if they bend down and they are really short of breath, that's a sign that they're still congested. And obviously look for your JVDs and hepatojugular reflux. So the central theme is getting them from this congested state to their decongested. So this I felt was an important slide in the overall article that talks about what are our different assessments and what are our decision points that helps us decide on what is the actual risk for these patients, both for readmission as well as for their mortality. So on admission, it's pretty obvious, if they come in with significantly worse disease, causing class 4 symptoms, they're non-adherent, they are multiple studies showing that they're higher risk if they have a significantly high BNP. They have an elevated creatinine, BUN, and they're not producing enough urine after their first diuretic dose. They're diuretic resistant even after significant high doses of diuresis. And the degree of congestion at admission, they say, is not quite predictive of outcome, except that they are very predictive of longer length of stay. So especially if your patient has, a weight gain of 16 pounds more than their baseline weight, diuresing them in observation may not be enough because you have a long way to go in getting them back to at least half their baseline, half their weight gain from their baseline weight. And identifying those cold and wet patients on admission, identifying patients who are already with the low systolic blood pressure, trope elevation, hyponatremia, and who are starting off with no beta blocker therapy or no ACE and ARBs. They are often at high risk. So this is, pretty obvious, these admission factors at risk, the risk factors on admission, but the risk factors on discharge are a little more interesting. So, effective decongestion improves prognosis, and that's as I said, the central theme of the study, more focused on decongestion um, and focus education on hospitalization with improved home and community support. So these are all, given. What was interesting here is if they have a much higher reduction in their BNP levels, they're often associated with better outcomes. So checking their BNP level on discharge is really important, because if they haven't come down on their BNP levels from their admission, then they don't have a good outcome. So then you have to really reassess to see, are they really ready for discharge, because they're going to come back and get readmitted pretty soon. And this is also interesting. Often I've seen aggressive diuresis on day 1, on day 2, the creatinine bumps, and then the diuresis is backed off. I feel that is often a wrong approach. And that's what this consensus statement also says, that if you have just a small increase in their creatinine accompanying successful decongestion, they're often associated with better prognosis. Um, so that's a good statement here that we can aggressively diurese, and even if you see a slight bump in their creatinine, as long as they're achieving successful decongestion, that is good for the patient. So keep going, um, but stop. If your creatinine is starting to get much higher, if you notice a doubling of their creatinine, if they go from 1.2 to 2.4 the next day, then maybe something's wrong. But if they go from 1.2 to 1.6 um, with successful decongestion, they are expected to start to get better, and they often have a better prognosis. And patients who often have high BUN at discharge have a higher risk of mortality and readmission. And they also talk about how low total urinary sodium excretion may be a more important marker than actual urine output, which is something we don't really do. We don't really check urine sodium levels on these patients. But that's also an important tidbit to think about those difficult patients where you're not sure that may be an option. Diuretic resistance, again, another big issue that leads to worse outcomes and worse length of stay. And residual congestion, even after treating them with adequate diuretic therapy. So these are often patients at high risk and high risk of readmission. And discharging them still being cold and wet is considered a no-no because they often come back again with cardiogenic shock and in a much worse state than they got discharged. Low systolic blood pressure, again, is something that was focused on in this study or this consensus statement. This is something that we always try to achieve is to maximize their dose, and often you can see that patients with congestive heart failure being discharged with low systolic blood pressures. But if your patients is extremely low, down into the 80s systolic, then probably they are not ready for discharge. And troponin elevation, obviously, anytime the tropes are high, patient risk is high, regardless of what their diagnosis is. And hyponatremia, if you're discharging a patient with a lower sodium than they came in with, then that's also a problem and predicts high risk. And this is the last point here is often considered really pivotal for us to continue goal-directed medical therapy. A lot of times it's not uncommon for these agents to be stopped either because the patient's hypertensive or the kidney function is worse. But complete discontinuation of this therapy without restarting it is often associated with poor outcomes. And there's a really hard emphasis on starting these patients on goal-directed therapy. There's a lot of studies that show that if you discharge that patient on goal-directed therapy, rather than leaving it out to the next provider to handle, they often have a better prognosis. If you discharge them without any goal-directed therapy, especially ACE and ARBs, and without beta blockers, and ask, say, for example, the primary care to restart it, often that gets missed, and the patient ends up being without goal-directed therapy for a longer time, leading to higher risk. So whenever you're getting ready to discharge your heart failure patient, it is extremely important to make sure that they are discharged on at least an ACE or an ARB or a beta blocker, or you have sufficient documentation saying why you are not doing that. Because discharging these patients without these agents confers a higher risk. So this sort of is just reviewing this few points on the reassessment and discharge often helps us to predict how these patients are going to do on the outpatient setting. So even in the observation unit, make sure that your patients don't have any of these higher risk factors when you're discharging them, or if you are, uh, you may need to discuss with your cardiologist to make sure that the readmission risk and the mortality risk is lower. All right, so trajectory check and what to do when you do that trajectory check. So we talked a lot about admission and risk factors at discharge. So what to do when they are here? So you have a patient in the observation unit, you're diuresing them, they're doing well. Then what do you do? So if they're improving towards their target, you need to start thinking about transition to their oral therapy. And it's very important to remember that all these transitions are not days. So it's not like you start them on IV on day one and you do your trajectory check on day 2, and then you transition them to oral therapy on day 3, and you discharge them on day 4. So these are not, one-day events. These are actually events that can happen all in the same day. So you can start them on the ER could have started them on IV diuretic therapy. You can be the person doing that trajectory check to see if they're improving towards their goal, and start them on oral therapy within the next 6 hours, and then reassess for discharge within 18 hours in the observation unit. So all of this can still happen on the same day. So this trajectory check essentially will help you to see if this patient is improving, to double the dose. So doing that check early on in the process of hospitalization often helps these patients to get assessed early, to be upgraded early, and also to be discharged early because they are getting decongested faster. And always think about your goal-directed medical therapy when it comes to discharge. So what happens if they are not improving? So initially they improved a little bit. So they improved really well from the ER. You continued their diuresis, and they are not improving in the observation unit. Then you need to escalate their therapy. So if they improved with 40 of IV in the ER, and you reassess them in the observation unit, and they're still struggling to breathe, they're still appearing wet on exam, or they have cold extremities, then you need to either increase their diuresis or consider having expert support. If you have a heart failure hospitalist or heart failure cardiologist in-house, reaching out to them, or just reaching out to general cardiology and asking them to help out. And one approach that I found really helpful is actually talking to their own cardiologist, even if they are outside the system. Before you call the cardiologist in-house, they will be able to help you manage that patient in a much better way, because they know that patient from their admission, from prior to the admission, and also will be able to follow that patient post-discharge. If they don't have a primary cardiologist, then getting a cardiology consult will be appropriate at this time. So this trajectory check can happen at different points during their care. It can happen really early on, can happen on day 2, or can happen on day 3, depending upon how the patient. And can also happen at multiple points. You can have a trajectory check, patient is improving, and then if they're not improving, then recheck them again and decide on what you're going to do next. So if they're not improved or worsening, obviously these patients needs to get admitted. They need to be escalated. They might need to be considered for IV inotropes or advanced heart failure strategies, and really to reassess the entire picture and maybe even consider palliative care if the patient is not doing well. All right, so another focus on this guide was to really talk about transitions, and one of the transitions that we handle is discharge to the next provider following them up. So they wanted to make this standardized across health system. Different health systems have different, discharge requirements based on multiple quality projects that are happening regionally. But these are like the core points that has to be in your discharge summary. So if your patient is getting discharged from Henry Ford with the diagnosis of heart failure, your discharge summary will automatically include a lot of these points. It's very important that you don't remove that segment from your discharge summary and keep it, because these were developed based on the expert consensus guidelines, and also will help you recheck and reconfirm that you are considering goal-directed medical therapy, either if you haven't, well, that you're ordering it. If you are not ordering it, then why you are not ordering it. The reason for not ordering is captured. So essentially, when you're doing your discharge summary, make sure you are touching some of these points, like why did this patient come in, like were there any sentinel symptoms, and what was their congestion status when they came in, what dose of diuretics helped them really well. And one thing that this update focused on is including a rescue plan for patients when they get discharged. So when they come in and you're diuresing them and you double their dose of diuretics and you're discharging them, always give the patient a rescue dose. What happens on that day when they're still feeling congested despite taking their diuretics? Having a rescue plan, either asking them to take an extra dose of diuretic or taking a dose of metronidazole that day, that often helps to prevent worsening heart failure from developing and also helps in preventing readmission. So including a rescue dose becomes very important in these patients. And also, what to expect if they have any unexpected events, patient needs to be appraised of those. And plan therapy, so this part of this is covered under the discharge summary addendum that shows up automatically for all heart failure discharge patients. Talks about goal-directed medical therapy and what are the different follow-ups that have been set up, and also some recommendations for primary care physicians on when to reassess response to therapy and also to consider vaccinations. And regular follow-up to some of the other comorbid conditions that could be affecting heart failure. So if you find a patient is significantly iron deficient on admission and you corrected their iron deficiency anemia, consider either discharging them on oral iron or having them follow up with their primary care doctor if you feel, even a hematologist, to correct their iron deficiency anemia, or even a GI physician to see if they have acute or chronic GI bleeding that's leading to iron deficiency anemia. Assessing and correcting some of those comorbid conditions can help you improve your heart failure management, and especially help the next provider to manage them better. And always look for psychosocial issues. All our patients who are getting discharged currently are being seen or should be seen by a case manager who will go over the patient's heart failure education, who will also discuss with them about different psychosocial issues. There is a renewed plan to look at these education that's being given to these patients, to see if we need to have a dedicated personnel to do this type of heart failure education to these patients, and to also help them coordinate between the inpatient case managers and the outpatient case managers so that we can handle the psychosocial issues and the social determinants that help with improved management of heart failure. And contingency plans on what could go wrong with the expected plan, and including a rescue dosing for these patients often becomes very important. And also always think about the question of, is this patient going to survive the next year? So if you have real good skepticism that they may not, then it's time to consider advanced care planning and palliative care consultation on these patients. All right, so what is different from the previous guidelines in 2016 and 2017? So the previous guidelines were heavily focused on just the therapy of heart failure, goal-directed medical therapy, what medications to give them, what is their level of recommendations, what is the strength of evidence, and really doesn't talk much about how to practically manage these patients in the hospital. And some of the updates, especially the 2017 updates, a huge list of medications, gently nudging providers to consider trial doses of medications rather than starting them on significantly lower doses on discharge or prior to discharge, which was a difficult approach to follow when your patient has a systolic blood pressure of 110, just because the beta blocker trials suggested that the average dose used was 160 milligrams of metoprolol XL. Are you really going to discharge them on such a high dose? Or are you going to titrate them or start them from a much lower dose and go upward? So this was always a question that nobody was able to answer, or nobody had a consensus on, but was on the guidelines, and it was up to us to either follow them or to do our own plan. And obviously there was multiple different styles of management leading to variations in care. So what this guide essentially helped us is move away from the class of recommendations and the strength of evidence-based way of recommending things. Not to say that they are not relevant anymore. I think they are still very relevant, to consider the strength of recommendations for these medications, especially goal-directed medical therapies. There's really a lot of evidence and good evidence supporting that, and every patient should be considered for that. But then gives us room to think about starting them on a lower dose so that they are able to tolerate these doses and then uptitrate them on the outpatient setting rather than not knowing what dose to start them on when they're getting discharged. So that was a bigger deviation from the way these consensus statements and these guides have been coming out from the ACC and the AHA. So that was very important to know. And more focus on inpatient clinical management and discharge rather than outpatient management. This was a focused update that was very focused on hospitalization. So no wonder it was heavily focused on inpatient management. And that was a sort of a hole that the ACC and the AHA haven't really addressed for a long time. There was a lot of focus on getting patients to goal-directed therapy, but not really a major focus on what happens when they're in the hospital. So this laid out a clear strategy and a plan of managing heart failure patients right from admission to trajectory checks to transition to oral therapies and discharge and their first follow-up. And talks about other drugs, especially drugs that don't confer mortality benefit, like diuretics, and what to do with their potassium levels, and is digoxin helpful or not, can we use it or not, and which patients to use it. So if you actually look at the medication part of the article, it gives you practical points on how to approach these patients, and that I feel was beneficial. And some of the highlights from this guide was obviously the ARNIs and the SGLT2 inhibitors are coming up, and they're going to be slowly replacing ACE and ARBs. And not a lot of data on SGLT2 inhibitors, Jardians and empagliflozin and all the other group of medications because there's not enough studies. There are studies about using these meds on the outpatient perspective for specifically for heart failure patients. And that's being looked at even when they don't have diabetes. So there's, I think, the DAPA-HF study that looked at this. So that's very interesting, which may be coming up in the future. And also focus on ivabradine use, that it's not really indicated before you achieve maximum beta blocker titration. And still your patients are tachycardia despite being on high doses of beta blockers, then that's being considered more. And more practical updates for especially heart failure with preserved ejection fraction, which was sort of a population that was left out. And this helped us to streamline management and made the management more clear for what to do with these patients when they're admitted to the hospital, which is not really different from a reduced ejection fraction, especially when they're in their congested state. And heavy focus on this guide on discharge and follow-up. We actually look at the article. There's multiple pages about flow sheets upon flow sheets on what needs to be done on the first follow-up, what needs to be done on the first follow-up phone call. So these were really good guides on setting up heart failure readmission reduction programs for health systems across the United States. So we are more uniform in what we do, and our message to the patients is also more uniform. So that's pretty much the updated 2019 ACC consensus on heart failure. Very interesting guide to read, very easy to read guide as well, that anybody can understand. Very pictorial, so you have a lot of pictures. Almost all of these pictures were from the article itself. And I would urge every one of you, if you haven't read it, to go through it, to update yourself and to give yourself backing if you've been doing the right thing. I think this guide has been one that lays out and standardizes the management of heart failure, especially I feel with the initial diuresis and what happens at the trajectory check level and doubling the dose of diuretics and not withdrawing diuresis early on just because you saw a slight bump in their creatinine. I think all those statements really help to standardize heart failure management on the inpatient side and helps you to to go ahead and aggressively diurese these patients with the goal of decongestion early on, and also looking at the risk factors at discharge. So you're not discharging patients who are at high risk, which was also an area that was less focused on because we didn't know what was the point of discharge. Is this patient actually safe to go or to stop, or needs more diuresis or should be held back? So that also was much more clearer in this article. So if you haven't already read it, I would strongly encourage you to go ahead and read and benefit from it. All right, now we'll open up for any questions from anybody online.
Hey Brian, thanks for the talk. I have a question.
Yes.
So I'm not clear with the in.
Hello, go ahead. Shri?
Yeah, okay. My question is, can you hear me?
Yeah, yeah, I can hear you. Go ahead.
Yeah, my question is, when the decision whether the patient comes to inpatient or observation is made in the emergency room, are the intercall criteria in line with the recommendations these guys have made about which patients should go into observation and inpatient?
So, they haven't.
Hello?
Yeah, hello. Can you hear me?
Yeah.
So they haven't really laid out like the specifics as Interqual does. I mean, Interqual criteria is more focused on, what is their oxygen saturation on admission? Are they hypoxic? Are they getting high levels of diuresis? Are they getting, are they on a diuretic drip? Are they on high levels of oxygen support? It doesn't really talk about, risk factors. So interqual criteria is more about acute management, um, which I think when I read this guide, that was the first thing that came to my mind is that there's going to be a conflict between the guide and interqual because interqual will say admit to observation, but these patients will be extremely high risk, especially if they're coming in with hyponatremia and AKI, for example. But to the interqual criteria's credit, I would say a lot of them are actually aligned with all these risk factors, but they just give a number to it specifically. So if this guide said worsening renal function, interqual will say the renal function should have worsened up to 2 times the creatinine. So you can still say both of them are correct. And understanding these criteria will be difficult because they keep changing every year. So I would still rely on what the decision is made from IPAS or from, based on which patients go where. And then it's really up to us to do that trajectory check to see if they're improving or not. And when we do that check and we mention or we write in our note that the patient is not improving with the current diuresis, or the patient is 20 pounds above their weight, they are not able to ambulate even up to the bathroom, all those, the trajectory check often helps us to make them more qualified to be admitted because we already tried a dose of diuresis and they haven't improved. So I think there's more room to use this guide in the observation unit, even if you do get a patient who's not, appropriate for the obs unit based on this guide. But doing a trajectory check and seeing if they're not improving despite their initial IV dose often will make the case that these patient needs to get admitted. So it's very important to do that check early on. And the guide focuses mostly on, at least the half of this guide was focusing on, do trajectory check and deciding that point early on in the management of this patient.
Okay, thanks.
Okay, any other questions? Or
For a great topic, such a high touch topic for us. Thanks for the discussion.
thanks, Heidi. All right, so I think it's almost 12:56. So thank you everybody for participating. I'm going to reach out to one of our cardiology team members. We're in discussion about the next part of this talk after our readmission group has sort of convened and worked on. So that process is going to take a good 3 to 4 months, and probably early spring 2021, we will have part 2 of this guide discussion where we can discuss with one of our cardiologists from the main hospital on what they think about this guide, where it excels and where it can be a little better. So that way we can also have a review of our readmission protocols and education that will be rolling out to patients at that time as well, and also an updated heart failure order set that is also being considered and in the works. So the next talk based on this topic of heart failure will have one of our cardiologists participating as well. So I would recommend everybody to participate in that next one. Thank you so much for taking part. We'll see you all soon. Thank you.
Thanks, Brian.